Hi guys, it's a pleasure to talk about AngioVac thrombectomy, which happens to be quite frequently performed at UCLA. It's a multidisciplinary collaboration, and I have to say we work really well together with CT surgeons, cardiologists, as well as our perfusion team. These are my disclosures. I am a consultant for angiodynamics and a co-PI for Apex AV, their IDE trial, which I will be talking about just briefly in this. So right heart thrombus falls into two categories. You can either have clot in transit and or in situ formation, and most commonly we see it in conjunction with pacemaker leads and our catheters or prior catheterization. The presence of free-floating right heart thrombus is a predictor of hemodynamic decompensation, cardiac arrest, and mortality, even in patients treated with heparin. So the AngioVac system is a mechanical aspiration thrombectomy system device that allows for large volume thrombectomy in conjunction with veno-veno bypass or ECMO. The indications for utilization of the AngioVac device are intracardiac mass, cable thrombus, catheter-associated thrombus, endocarditis, vegetation removal. So the RAPID registry was the largest multi-center prospective registry of 234 patients who had undergone AngioVac thrombectomy for either cable thromboemboli, right heart thrombi, catheter-related thrombi, or pulmonary embolism. And the pulmonary embolism part of it is not indicated. Or off-label use, I'm sorry. So what the study saw was that there was successful thrombectomy defined by 70 to 100% thrombus removed in about 70% of patients with CTE, about 60% of the patients with the right heart mass, 60% of the patients with catheter-related thrombus, and about 57% of the patients with the PE. And you can see that John Moriarty from UCLA was the PI for this study. And again, pulmonary embolism was one of the categories, but it's off-label use. And I'll talk about this a little bit later. So the registry essentially indicated that this is a pretty safe procedure to be done percutaneously. Obviously, the mortality and morbidity related to this procedure is very low. A lot of people are very concerned about major hemorrhage, but that was only seen in about 2.6% of the cases. Cardiovascular perforation was actually one case of where they saw tamponade, which was managed with percutaneous drain, and the patient did fine. There were total 3 deaths in this study or registry, and 2 of those deaths were not related to the procedure. So overall, they saw that the extracorporeal bypass time was less than 1 hour, estimated blood loss was less than 250, transfusions were needed in about 1/4 of the cases, but majority of those cases that was less than 2 units of blood, and the overall complication rate was about 13.2%. So in 21, AngioDynamics was in the news because AlphaVac mechanical thrombectomy system was cleared by the FDA, and we're also going to talk about that a little later. So to do an AngioVac thrombectomy, the tools on the table you start with are a 22 French suction cannula. We have the old generation, which was essentially had a balloon around it, and the newer generation, which, if I can just go back here, has the same funnel, nitinol reinforced funnel, but without the balloon. An extracorporeal circuit that you can see here, debris collection port, venous return cannula, which is usually a 16 French or an 18 French cannula. You need 26 French access for this. We typically work over stiff Amplatz wires, and we like to keep our patients anticoagulated with the activated clotting time of between 250 to 300s. So the recent product enhancements, you have the F22 cannula, which is 22 French. This is the AlphaVac device for right heart thrombectomy. It comes in 20-degree and 180-degree angled tips. The 180-degree angled tip is usually very useful for endocarditis vegetations. The F18 is the new product that essentially will be tested in the IDE trial looking at the use of AngioVac or AlphaVac for PE thrombectomy. So The traditional system essentially has a working side port. It has a 2E insert, which typically allows for a seal, but you are capable of placing up to 17 French of adjunctive devices. So in this case, I'm using a snare catheter to essentially grab what was a endothelialized catheter-related thrombus and try to bring it closer to the cannula so that I can perform the thrombectomy. So, the cannula placements, are essentially, you can do it from the femoral approach for SVC thrombus, right heart. I usually, again, go with the femoral approach, IG approach rarely if I, essentially need to approximate it close to essentially for pacemaker leads and our catheter-related thrombi, and then you can also use it in the infravena cava. Procedure typically gets done under general anesthesia. We have TEE support either provided by cardiac anesthesia or cardiology. We get 2 access points. I usually just get an additional access point in case I need to switch from right IgA to right common femoral vein. I won't dilate to 26 French unless I absolutely need to. There's a lot of preparation for this procedure, and we work very closely with our either cardiac anesthesia team or cardiologists because majority of the case gets done under echo guidance, and so we kind of work side by side in order to approximate, and it's essentially over before you even know it, as long as you can get the catheter up there safely and then understand what you're looking at when you're looking at the echo images. Just orient yourself, and then essentially it's a no-brainer. So here's a bicaval view that's showing the AlphaVac device kind of approximating the clot, and then you can kind of see it essentially in 2 views, and there's the debris collected in the debris cannula or filter. Here's a case of patient with a pacemaker lead associated thrombus. He already had bilateral PE. CT showed that there was also common femoral vein thrombus. So unlike what Rahul was just saying, the echo images typically represent a certain amount of clot, and whenever we get it out, we always see that it's bigger than what it is. This is essentially an 8-centimeter mass that was removed from the right atrium associated with the pacemaker lead. So the AlphaVac device is basically 18 French, the new first-generation mechanical aspiration thrombectomy device for thrombectomy to be performed in the pulmonary circulation. It has an 85-degree cannula tip option. This is considered to be optimal on bench testing for access to the pulmonary arteries. Here it is. So we are going to an ECMO-less circuit. This is the actual handle, which is basically the control center for the device, and it allows you to minimize the amount of blood loss by having 10 cc and 30 cc options, and also a vacuum lock mechanism, which maintains negative pressure. So I'll talk about the Apex AV, just a little plug for the trial, which is coming up. Again, it's a prospective multi-center single-arm study, and it is to prove safety and efficacy of this device in the pulmonary embolism thrombectomy procedure. Brent Keeling and I are co-PIs. The timeline for the trial is 2022 to 2024. Again, we're looking at, like every IDE trial, we're looking at essentially the intermediate high-risk pulmonary embolism population and seeing if they would benefit essentially with thrombectomy, and change from baseline RV to LV ratio and any major adverse events are the primary safety and efficacy standpoints. Other things that we will look at are essentially major adverse events, including device-related death, major bleeding, a modified Miller index between baseline and 48 hours post-procedure, and then other secondary safety endpoints like pulmonary vascular injury, cardiac injury, major bleeding, etc. I think I'm done with 1 minute to spare.